Hi everybody, and welcome to Eye Contact, a video news program on issues and controversies in ophthalmology sponsored by EUROTIMES. I'm Dr. David Granet. We're reporting from the World Society of Pediatric Ophthalmology and Strabismus meetings here in London during the 32nd Congress of the ESCRS. With me today we have a real expert, Dr. Wagih Aclimandos. Dr. Aclimandos is a consultant at King's College here in London and past president of the European Board of Ophthalmology. Welcome.
Good morning. Good morning.
We wanted to talk with you about retinopathy of prematurity, one of the topics that came up yesterday during the meetings, because you are one of the experts. And retinopathy of prematurity hasn't changed in that it still is afflicting more children around the world and causing blindness everywhere. So one of the things I wanted to ask you was, what are the new changes or recommendations in screening children so we can identify who needs treatment and our help?
Well, there are, of course, a lot of factors that affect retinopathy of prematurity and can cause it. But the crucial ones remain the same, which is the degree of prematurity and the low birth weight. Many other factors vary and vary around the world. And the crucial point is screening. So there are a lot of newer treatments and new theories, but the basics remains the same, which is very premature babies and very low birth weight babies who need to be screened. And this is a problem, particularly in the developing countries where babies are kept alive because they have got the incubators and things are moving on from the perinatology care point of view, but there isn't necessarily the eye service or the screening service to parallel this. And it's a real problem because it's a very tedious exercise, as you know well, and it's only from time to time that you find a baby who needs treatment, and people get away with it. And yet, unfortunately, we get the referrals from different parts of the world where the babies have got to stage 5, and 2 or 3 months down the line, people say, oh, can we send this baby for you to see? And it's obviously too late.
So what would you like to see happen with screening around the world? Do you think some of the new technologies, like with telemedicine and imaging that can be sent to screening centers, might be of assistance?
I'm sure telemedicine is a very useful one because people who have now got enough money to buy the incubators, I hope would have enough funds to buy a RETcam and beam the pictures to someone who can make a judgment and make sure that treatment happens in a timely fashion.
Now, even in the developed world, children still slip through screening protocols or still have to be screened. Are there any new and updated changes that are happening with that?
Well, it has always been a problem because the rarity of the problem, the fact that only few babies are found to have the disease, means that we have to be very diligent in the screening. And from time to time we go on holiday, and many units depend on one expert for the service. And that really creates a problem because to provide the service 52 weeks a year, screening is sometimes a challenge. So you need to have arrangements, often local arrangements, to cover. And I'm sure that telemedicine is again a very helpful tool, because even within south of England, to have a baby transferred from a center where he's been screened and found to have retinopathy that might require treatment to a center where he can be treating can be quite a challenge. You want to make sure that incubator is available, that the surgeon is available, the time to do the treatment is available, and all that within the small window we have to actually do the treatment.
You mentioned treatment several times now. For a long time, no one knew what to do. Then we were thrilled that we had cryotherapy. And laser was a huge advantage and still is the mainstay of what we do. But now there's a new treatment that's been promulgated for retinopathy of prematurity. And I wonder if we can take a couple of moments and just talk about that. And that are the VEGF-based drugs. What do you think their role is? Is there a role? And where should we be going with this?
I'm sure there is a role. And we have all for years been dreaming of the day we're going to find a treatment that does not involve destruction, which is what cryo did and what laser does. So I'm sure the future is pharmaceutical and how we manipulate the chemicals. My problem with the anti-VEGF is that it is great, but in some very specific situations. So I think disease which is very far back, very aggressive, zone 1 disease, yes, anti-VEGF is a good idea. My slight concern is that people can see it as the easy option. And actually yesterday, talking to someone from the third world, he said, we don't have an indirect laser, and therefore all babies with ROP, we inject anti-VEGF because it's there for the adult population and it's easy and quick. So he said, we don't have the time and we don't have indirect laser, so we use anti-VEGF. And I think we must have a word of caution here, not to abuse it. I always feel that there are so many lessons to learn from ROP for the whole medical profession from the history of ROP. The fact that for 25 years we have all believed in the vasoconstriction, vasoobliteration theory, when we never saw a vessel shut. Vessels get dilated and distorted and tortuous, but we never saw a vessel shut. And yet, for 25 years, we all believed what the textbook said and continued to talk about that theory. We must be a bit critical about even what we read in the textbook.
Yeah, it reminds me of the origination of ROP, where babies were getting oxygen to keep them alive because everyone thought that was a wonderful, great approach, and we blinded all these children. Does VEGF or anti-VEGF treatment have that concern that we're going to cause damage to children as well?
Precisely. I think we just have to learn the lesson from the past, as you quite rightly quoted. After the oxygen was found to be part of the problem, there was the 40% oxygen rule in the US, where for a period of time no baby would be given that, more than 40%, and it took time, which is surprising in hindsight. People took time to realize that it doesn't matter how much oxygen you give, what matters is how much oxygen gets in. And we should measure the arterial oxygen as opposed to how much we give. And this is another lesson to learn from the ROP and the development of the understanding of the condition and its treatment. So I think anti-VEGF is a wonderful medication, but no one is yet sure which one to use, the correct dose. Is it 50% of the adult dose, which is now the most commonly used dosage, or could it be that 25% would use it? Because if we're going to suppress the growth of vessels, we want to make sure we don't overdo it. So it's a fantastic tool for these aggressive diseases, but we have to approach it with very cautious and thoughtful studies rather than randomly.
Dr. Aclimandos, thank you so much for joining us during what we know are very busy meetings here in London. For more information about this and any of the topics that you've heard today, go to eurotimes.org. I'm Dr. David Granet, and this has been Eye Contact.